Thank you for having me, and happy Lung Cancer Awareness Month. I just want to extend my congratulations to all of you. You guys are at the forefront of cancer survivorship. So I don't know if many of you are aware, but for the first time ever, overall survival for cancer patients increased by 2 percentage points, and that was led by lung cancer survivors. So hats off to all of you, because you single-handedly improved the survival rate for all cancer survivors in the United States last year. So awesome work. And I'm going to talk a little bit. I'm going to share my screen just so that I can keep my brain on tack, but I promise I'm not going to dive deep into a bunch of radiation oncology and physics. So first of all, with my work in survivorship, what I realized when I started talking to lung cancer survivors is the burden that is being a lung cancer survivor. And I would just like for everybody to take a minute and realize that you are at the cutting edge of lung cancer survivorship. And for anybody who is at the cutting edge of anything, there is a lot of burden and a lot of pressure on being the only ones out there. And I see that and I recognize that. And that's one of the reasons that we started our cancer survivorship program. And the first publication that is coming out, we're putting the finishing touches on it right now. And I'm presenting on lung cancer survivorship at a national thoracic meeting at the end of the month. It's because I think that lung cancer survivors are overly burdened with being survivors, having to constantly explain themselves, and also to be a small group of very loud voices. And Dusty has really been on the cutting edge of that and encouraging that. But I love this Mary Oliver quote, that it's enough that you just survived lung cancer. Everything else that you're doing on top of that is icing on the cake, but you guys really should pat yourselves on the back for surviving a very deadly disease. Just to give a broad sense of where we are in survivorship, we are ever increasing the number of cancer survivors that are alive in the United States. And in 10 years, there's going to be about a 25% increase in survivors in the United States. And that's both due to early diagnosis, low-dose lung screening in particular, also improvements in treatment, including immunotherapy, which you all, I'm sure, are well-versed in, as well as just an expanding life expectancy. Unfortunately, that is going to be paired with an oncologist shortage. So the baby boomers of oncology are now retiring, and we don't have as many oncologists entering the workforce. We also need to increase our space for new patients. So as survivors are accumulating in our clinics, which is wonderful, and we love seeing you guys. I've talked to Jeff Petty many times about sending some of his patients to survivorship. And he always tells me, Stacy, we've worked so hard to get lung cancer survivors. I just love seeing them. So he also wants to hold all of you very close to his chest. And also, again, increasing survival. I do think there's an argument to be made about making survivorship an actual transition. So the same way that we celebrate high school graduation or college graduation or even kindergarten graduation. These are important milestones. And I think that transition to survivorship, which in some patients can be maintenance therapy who are living with metastatic disease, or in some patients, it's then transition from cancer treatment and an illness mindset to a wellness mindset. I argue that we should be doing that in a more systematic way. Just what is survivorship? You can get in and I find that when I'm talking to survivors about survivorship, I think you can get in a cul-de-sac of what is survivorship. To me, I think of a cancer diagnosis as this little car going down the road, and then all of a sudden you're diagnosed with cancer, and all of a sudden you find yourself on a road that you did not want to be on. Survivorship to me is kind of re-entering the world. You can still be a part of the cancer community and you're still seeing doctors and still need maintenance, but it's out of that scrum of the initial diagnosis and back to what does it mean to live with this diagnosis and after this diagnosis. And to me, that is survivorship. You will hear people talk about survivorship as from the moment of diagnosis onward. But from a programmatic standpoint, I talk about survivorship as maintenance of life after intense treatment, or the transition to life after treatment, acknowledging that truly everyone is a survivor at diagnosis. What I would like to sort of bridge the gap between the patient experience and the physician experience. I will tell you that hardly any physicians receive training in our medical school or in our residencies on cancer survivorship. So if you've ever gone into a doctor's office, asked a question, or into your oncologist office, asked a question and be met with a blank stare, or I don't know, but it's not cancer, or looking for resources and not having any, it's because what we are taught is what's on the left hand of the screen, which is called medical surveillance. Is your cancer back or not? And that is really the bulk of our training as oncologists, is doing physical exams and ordering the proper laboratory testing and imaging testing to evaluate the response or non-response of your treatment. What I think we need to move away from, and that is a very classic training, what I think survivorship entails, and my argument for survivorship, is we really need to move into education and engagement. And that starts and is present in a lot of different ways. So this education and engagement piece, though, is not a part of our normal medical training. What that involves and what that necessary piece is a lot of these things, which is treating the patient not just as a cancer survivor, but as a whole patient. And whether that is addressing physical symptoms, ordering other screening tests. Now that there are long-term survivors of lung cancer, we need to send patients back for screening for other cancers. 1 in 5 cancer survivors will be diagnosed with another cancer, and we need to be doing a good job of finding those cancers early. As genetic testing increases, are there any genetic tests that we need to run that perhaps weren't available at somebody's diagnosis 5 or 10 years prior? There's also the emotional, the PTSD of cancer treatment. What does cancer mean? What just happened to me? How do I process where my body is right now and the new reality that I might be facing due to my treatment or my disease? Then there becomes this shift in survivorship, I think, to self-management. And what I've heard from survivors is, I want to know what I can do. A lot of cancer is out of your hands, but if there are things that I can do, I want to be doing them. I don't want to find out about it on some message board. I want the doctor to tell me, how can I be doing better, and how can I improve my life with cancer, or how can I prevent cancer from coming back? There's also this important aspect of care coordination. So I'm sure many of you, if you're like most survivors I talk to, have felt like a hot potato. Oh, that's your primary care responsibility, or, oh, that's not my responsibility. And I'm seeing several shaking heads that, yeah, that's been something. That's your pulmonologist responsibility. Don't talk to me about that. I'm not in charge of that anymore. And I think that as the intensity of cancer treatment decreases, coordinating that care of who's taking care of you and who's the quarterback now is something we need to do a better job of. And then important other wellness issues like vaccinations can be important in preserving health of our cancer survivors. I will just briefly touch on the most common physical symptoms that I hear from cancer survivors before I go into sort of how we approach lung cancer survivors and how you can advocate for lung cancer survivorship programs in your community. Physical symptoms are something that are not well documented, and the treatment for those physical symptoms is not well documented in lung cancer survivors. Like I said, you guys are a small, loud group on the outer edge of survivorship in your disease. So we don't have a lot of good data on what your long-term symptoms are and what the best interventions are. A lot of times we're taking tools from other disease sites and trying to apply them to you, hoping that it works. But many times I find this sort of, I call it the bake sale approach to survivorship, which is just we're kind of like figuring out what everybody else is doing, leaves patients with, hey, this isn't working, and they're emailing their doctor, sending my chart messages, and really not getting what they need. I will say there is a Comprehensive Cancer Survivorship Act that is a bipartisan act that's been introduced in Congress that I'm working with the National Coalition for Cancer Survivorship to try to get passed, because we need better data on how to take care of you guys. A lot of times we don't know. There is not a lot of evidence on what to do for a lung cancer survivor. So we need better data, and we need evidence-based guidelines for how to address some of the most common aspects for lung cancer survivors, not just what worked in other diseases, but what's working for you guys specifically. In my experience, I think fatigue can be multifactorial. I think a lot of times we just say, oh, it's your disease, or, oh, you're just recovering from treatment. But I do think that there is an important correlation between lung cancer treatment and also heart disease. So I always recommend that a patient is referred to cardiology to make sure that we're not just attributing this to side effects from treatment or to your lung disease, but we've also maximized your heart health. The heart and the lungs work in concert to provide energy to our bodies. I also find a shockingly low number of patients that have been referred to pulmonary rehab. We would never discharge a patient with a knee replacement and not send them to orthopedic rehab. So the fact that most lung cancer patients are not taught ways to improve and maintain the muscles of breathing so that they can so that you can breathe the best that you can and maybe improve your stamina is mind-blowing to me. This is paid for by Medicare. It is a part of all cardiopulmonary rehab programs, which everybody who does CABG surgeries or cardiac bypass surgery has a cardiopulmonary rehab team. So talking to your pulmonologist about, or to your oncologist about being sent to pulmonary rehab is really important. And also, again, part of the Comprehensive Cancer Survivor Act is paying for cancer rehab. I am done hearing about how cancer patients are just done after treatment and good luck. No, we need targeted evidence-based cancer rehab. We know we have some evidence on what works for cancer patients, and we can't just expect patients to just recover from treatment on their own by figuring it out. We need to have a program where patients can improve their health in a evidence-based and supervised way, similarly to patients who've had cardiac bypass and patients that have COPD and are referred to pulmonary rehab. Neuropathy is another disease or another symptom that patients complain about a lot after treatment, especially after chemotherapy. This can also be due to arthritis and diabetes. I have had great results in referring patients to physical therapy. I mean, they're going to work you, but there is such an improvement in the tools that physical therapists have to improve movement and to improve pain that I have really started insisting on patients really being evaluated by physical therapy to figure out if there's a way to improve that pain and, again, improve mobility and quality of life. I also encourage patients to work with an integrative oncologist. The Society of Integrative Oncology has multiple guidelines set out on the use of acupuncture in controlling neuropathy. There's actually a trial at Wake Forest right now looking at intervening with acupuncture before neuropathy develops. And so there are multiple programs here in North Carolina. I do recommend that you work with a program that's associated with a cancer center, because you always want to work with a provider and a practitioner who is familiar with the unique situations such as low blood counts and other issues that are common in cancer patients. I also, a lot of patients struggle with decreased appetite and losing weight. If you have not seen an oncology specific dietitian, I'll give you some resources at the end. I know you guys have heard from Julie Lanford. I love Julie. And I also recommend that patients see speech therapy. Again, the esophagus is a muscle that's in the chest. It can be damaged by my radiation. It also is a muscle that weakens over time. So a lot of patients after treatment are having problems swallowing. Things don't taste right. The muscles have atrophied from not swallowing or just swallowing liquids. So again, sometimes there aren't a lot of things we can do for specific symptoms, but if we're not trying to eke out that 5 to 10% to improve quality of life, and we're just saying, oh, this is your new normal, I think that's got to be our last option and our last recommendation to patients after we've exhausted all these other options. So you've already been sort of attacked by a tiger that came out of the jungle. And unfortunately, you're still a human. So you have to go back to your regular health maintenance and maintaining all those other annoying things that happen as our bodies age: high blood pressure, high cholesterol, all those other things. So as much as our patients sometimes want oncologists to take over their care, it really is important that you have somebody else out there who is looking out for your other health issues and screening for other important causes of mortality in adults. I will say, I had one patient say, well, I just like talking to you, Dr. Wentworth. Can you manage my diabetes? And I will say that when I was taught to manage diabetes, we only had 70/30 insulin. And so that was about 20 years ago, and that would not be the best care for her. So although I'm a great radiation oncologist, I'm not the one to manage your chronic medical issues. And my husband will attest to that as well when he asks me questions about whether he should start an aspirin or stop an aspirin and all that stuff. I also think that as physicians, we need to be more tuned into the emotional processing of cancer. I think there are several studies now, starting in the 1980s. You would be surprised to know that doctors felt like patients should not go to support groups and should not talk to each other. There was a big hesitation in the medical community saying, oh my gosh, patients are never going to want to sit and talk in a room. What if somebody dies? What will they do? How will they process that? And there were some really great PhDs and psychologists that looked around and said, you doctors are crazy, we're doing this anyway, and actually showed that what you guys are experiencing is, yeah, we know that people are going to die anyway. We understand that's going to happen, and we'd rather be around each other and figure things out together and support each other. And the emotional benefits from groups like this are just through the roof, multiple papers showing that over the course of the last 50 years. So I do think as doctors, we might not be there for the emotional processing part of that, but that doesn't mean that we can't put you in touch with groups like LiveLung, and also in touch with our own professionals. We have our cancer patient support team who are filled with wonderful psychologists that help sort of put that furniture in your brain back to where it needs to be. I'll talk a little bit about our lung cancer program. I think this group is from around the country, right, Dusty? Is that sort of in different locations? Okay.
That's correct.
Okay. So I'm going to talk a little bit about the program that we put together. And this is just sort of to give you a sense of what lung cancer survivorship could look like so that you guys can advocate for that in your communities. As much as I would like, our new NIH director for the first time is an oncologist and a cancer survivor, Dr. Monica Bertignoli. Super excited to have a person who loves cancer patients at the top of the NIH. And as much as I would like Dr. Bertignoli to pronounce me queen of survivorship, I don't think that's going to happen for a while, or maybe at all. But I do think that you guys can be powerful voices in your own communities. So this is our survivorship clinic. We actually decided to create a separate place for patients to be seen in survivorship. We felt like there was a lot of trauma associated with being in the place where you were told that you had cancer or were recovering from cancer treatment. So we actually put it on the second floor and really created a separate space that has a very different feel from the busy oncologist office. And that has been a very positive. We've had multiple patients have positive feedback of having that in a different location. We actually have done an embedded model. So we take nurse practitioners and PAs that work with doctors, and we bring them down to the second floor clinic to see their own survivors. And that really has built patient confidence as well as provider confidence, because the patients know the people that they're seeing, and the providers know and have trained the people that are seeing the cancer survivors. So we have a half day a week, usually, sometimes for lung cancer survivors, which is our largest group and our most growing group of survivors. We have a full day where they're seen by different nurse practitioners, physicians, and PAs. This is our pathway to survivorship. So right now we have patients seen and diagnosed and then undergo their treatment. Based on their treatment, they are sent to different pathways into survivorship. For most of our definitively treated patients, so patients that receive only radiation, only surgery, or chemotherapy and radiation together, those patients are seen at a 1-month follow-up visit and then transferred immediately into survivorship. To me, this is what I have worked with Atrium on, is to try to get this for every disease site. To me, every patient should have a plan for survivorship. We are not treating you to be a cancer patient for the rest of your life. We're treating you to be a cancer survivor for the rest of your life. So that, I think, this pathway to survivorship, like what is my pathway to survivorship, is an important question for patients to be asking health systems. We built a referral in Epic. Physicians, for the most part, live and die by the electronic medical record. I will, just as an aside, if you're having a hard time getting in contact with your oncologist, we are constantly in our what's called an Epic inbox. So very rarely are people manning phones anymore. And a lot of times in these big health systems, the phone tree is like outsourced to somebody in like North Georgia somewhere that is not your doctor's nurse anymore. So if you have not downloaded your MyChart app or your app on your smartphone, I start patients at diagnosis now, and I will even have my nurse walk through that. How do you download that? Because talking to your doctor, and sometimes it's your doctor's nurse or medical assistant who's managing that communication, that is the easiest and the best way to get your symptoms across and to get the best communication from your doctors. Side note. What we did is we created a referral to survivorship. And so that allows that referral goes into a work queue and is then managed by our wonderful scheduler, Deborah, who then places the patients in our survivorship clinic. Then patients are given an introduction to survivorship. So we realized that a lot of patients were having some anxiety about leaving their oncologist, which is completely understandable, and especially going to a different part of the hospital. So we created just sort of this brochure. There's also an introduction video that features me talking about what survivorship is and why that's happening. And that's been really helpful in sort of managing that transition, as well as the conversation with the physician and the PA as well. Before each appointment, the patients get a copy of this video of me explaining what survivorship is, as well as what we call patient-reported outcomes. Patients call them those dumb surveys I have to fill out every time I come to the doctor. And I will say that I would love to do more surveys, but the consistent feedback I get from my patients and practitioners is stop with the dumb surveys. So I've narrowed it down to just 2 surveys, but the more information we get from you, the better we can direct your care. So the first is what you guys are very familiar with, is the distress thermometer, which I'm really not a big fan of, but that is the standard for our institution. And the second is the Promise 29, which is actually a better tool for evaluating different issues that cancer survivors have. Both of these are sent to the patient's MyChart, and we encourage patients up to 2 weeks prior to their appointment to fill that out at home. You would be surprised to know that most of the data indicates that if we have you fill out surveys in the clinic, that the stress levels go up, and we get a lot more 10 out of 10s, mostly related to parking or traffic, or the frustration of not being able to have a wheelchair or not knowing where you're going. So we want to get actually what's bothering you in your day-to-day life. And that's better established and better measured if we have you fill it out prior to coming in for treatment on your MyChart app. Then so to me, all survivorship should be standardized. So we should have a standard list of what we think is important and what we need to know about each survivor. So when we were putting our clinic together, we got all the heads of the lung cancer program in a room and said, what do you want to know about your cancer survivors? And then we paired that with what the national guidelines say that every cancer survivor should have. And so our CMA, when she's rooming our survivors, goes through this list of questions that is then reviewed by the person who's seeing the survivor. And it really keeps everybody on track. And it also puts out, notifications if something's missing. So if somebody doesn't have a PA, or somebody doesn't have a PCP, or somebody hasn't gotten their flu shot, that raises a red flag in a way that doesn't require a physician to remember anything. So this is another way that we've sort of standardized our approach to survivorship. So there's not that, oh yeah, by the way, can I get my pneumonia shot? Or, oh yeah, by the way, my PCP retired, can you refer me to somebody? That's all established via the CMA's flow sheet. Survivorship care plans are very controversial, I think. I think when they're done well, it's a very good resource for patients, but when they're done poorly, it's just a pain for everyone and kind of stresses patients out. So the data on survivorship care plans is very mixed. And I think that's because nobody told us nobody asked patients and primary care physicians what they wanted to see in survivorship care plans. So oncologists just ended up putting a bunch of medical gobbledygook in them, and nobody really cared about how many milligrams per meter squared of cisplatin you got. But we thought that was like really important. So I think that's sort of why survivorship care plans have not been that successful. In our survivorship care plan, we really limited it to the basics, and we made it a resource document. So this is resource document that is broken up, as you can see here, by common needs and concerns, and then suggested interventions. And those wonderful surveys that patients filled out are reviewed by the APP or the PA prior to the appointment. And then they go through the care plan and sort of earmark different interventions and talk to the patient about referrals to any of these interventions for the symptoms that the patient's reported. And then all of this goes to, about 1 in 3 doctors is considering leaving the profession in the next 3 years, which should scare all of us. And a lot of that is due to the replacement of medical transcriptionists with doctors typing. So on average, your primary care physician is spending 2 to 3 hours of their personal time at home with their families, documenting on charts and trying to complete that before the next day's work. I heard that from RPAs and nurse practitioners. And so what we did is created this, it's not lovely to read, but it is all the documentation that is required and important for patients and for billing purposes. But what I did not want to do is to have practitioners spending 2 to 3 hours at night finishing their notes, because that's unsustainable, especially a lot of our practitioners are parents or caretakers for their own parents at home. Then at the end of the visit, it pops up this, what do you want to do next? And so a lot of medical records, and if you've been in your doctor's office when they've been pecking around at the EMR, is trying to figure out what the heck we need to do and trying to find an order. So again, every lung cancer survivor needs the same thing. They need a CAT scan and they need a follow-up visit. So at the end of the visit, the smart set pulls up with the common things that lung cancer survivors would need to be referred to. And the doctor, instead of hunting and pecking and trying to find that, the doctor or the PA can go through and click one of these, and then it's done. And there's no searching around. So it's sort of a one and done thing, which has been really helpful. And we, again, as I said, we've recently put together the first 3 years of our data. And this is sort of a breakdown of the survivors that we see. So we see a wide variety of survivors, especially mostly for Forsyth County, which is in Winston-Salem, which is where Wake Forest is. But a lot of people are coming from these rural counties around us. So I think that informs my job as the medical director of survivorship of where do I need to look at programmatic needs in rural areas, and how are we connecting patients to programs like this that are available through telehealth or Zoom platforms. We also are seeing an older population. So I think that speaks to the comorbidities and making sure that patients do have follow-up with other doctors who are, for example, different than a young Hodgkin's lymphoma survivor, where their main medical problem is going to be complications related to treatment for their Hodgkin's lymphoma. Our patient feedback has been very good. They love the survivorship clinic. They feel more empowered after meeting with the nurse practitioner or PA and going over their care plan. And we have yet to have a patient who asked to go back to 15 minutes with their oncologist, which as an oncologist, I try not to take personally, but as a medical director of cancer survivorship, I take as a positive thing that our patients and our physicians are seeing a real value add to specific survivorship care. We've done some really cool innovations too, which I'm pretty proud of. I will tell you that being a doctor, many people come up to us and want to get to you guys and say, hey, will you remember to? Hey, when you see Mr. So-and-so, will you remember to? And right after that person says that, and with the best of intentions, I say, yes, I will remember to make sure that I email Dusty that this patient wants to be set up to LiveLung. But 5 seconds later, my nurse comes up and says, hey, Mr. So-and-so is in room 5 with a blood pressure of 70/20 and needs to go to the emergency room. Would you come here? So just telling a doctor to remember to do things is not a very good way to build a comprehensive survivorship program. So one of the things that we did is we took those patient-reported outcomes, or otherwise known as annoying surveys, and instead of patients feeling like, why am I filling this out? Nobody reads it or looks or even follows up on all these things that I'm saying anyway. What we did is we created a alert in the chart. When a patient reports a moderate or severe level of one of the things that we're measuring, this alert in yellow pops up to our providers and says, hey, something needs to happen to this patient. You need either talk about them, talk about a referral, you need to address it with them directly. Something needs to happen because they have said something that is a moderate or severe, has a moderate or severe impact on their life. And so this is called a BPA. It's available in Epic, but really what it is it's a way to alert physicians that there's something happening in a patient's life that they need to act on. And that's through an objective, through something that the patient is telling us, not something that we're maybe picking up, or also that our own inherent biases maybe are not picking up based on the stoicism, the culture, the race, or the age of the patient. This is objective data that the patient has said, hey, something moderate, severe is going on in my life, and you need to talk about an intervention. And you can see that you can say the patient declined referral. Hey, I was having a bad day. It's not really a big deal, but at least it opens that conversation, and it doesn't require the patient to feel the pressure of saying, hey, I'm depressed, I need to talk to somebody, or the doctor saying, hey, you seem short of breath when you came in through the clinic door today. How about, a pulmonology referral? When's the last time you saw a pulmonology? Instead, this BPA is coming up and saying, hey, you need to refer to something. So that's sort of what we're doing in our program. These are some of my favorite resources for cancer patients. These are all available online and are available to all of you. I'm sure Dusty has had some of these organizations talk to you guys. LiveStrong, I don't know that there's a cancer rehab in every single place. I do know that there is pulmonary rehab at every single hospital that does cardiac bypass. So that is available to you, but LiveStrong is available to any cancer survivor. Hirsch Wellness is a group that I work with that's based in the Triad of North Carolina, but they have many online offerings that sort of help process through art therapy, journaling, photography, knitting, yoga, Tai Chi, all of sort of the beneficial getting your brain back after being diagnosed with cancer. And then also Julie Lanford is a wonderful source for what do I do? Does sugar feed cancer? Should I be worried about microplastics? All those things about diet. This is a trusted source where she goes through evidence-based guidelines and how to modify your diet from a cancer standpoint. And Julie's a certified oncology dietitian and is really lovely. So I'm also doing a Substack. I started to have the same conversation over and over with patients in my exam rooms about what cancer is and what people think it is. So I started to sort of have the conversation about how do we bridge that gap. And you all, I'm sure, have experienced that of people wanting to say helpful things about cancer and then really not being that helpful. Or actually adding to your anxiety. Have you considered this? Have you considered that? You should be doing this. You should be doing that, that sort of thing. So we're sort of going through that in my Substack, and that's my website where it's other places that I'm speaking or talking. So that's sort of my overall view of lung cancer survivorship. And I'm happy to sort of talk about, I don't have access to your scans or your diagnoses, so I don't know about, I can really speak to individual plans, but if you have general questions or frustrations or things you want to talk about or things I've missed and I should be considering in lung cancer survivors. I'd really love to hear that and take that opportunity from you guys to hear about that.
As I type, some of those are just my personal situation, and Dr. Wentworth wouldn't have access to those. But, and I don't mean to put the doctor in an awkward place, but, I live in the Wilmington, North Carolina area. I chose to get my treatments at Johns Hopkins in Baltimore. And I quickly learned that North Carolina has some restrictive rulings on being able to communicate across state boundaries. And, my doctor at Hopkins is frustrated by it. I'm frustrated by it because I can't, according to the ruling, set up a Zoom meeting. I need to travel to Baltimore from Wilmington for, my CAT scans and treatments and so forth. Is there any progress in opening up this across state boundaries restrictions?
Yeah, unfortunately, if anything, the proposals that are working their way through Congress right now restrict that even further and have actually, the new Medicare guidelines just came out, and there's actually a 3% physician pay cut and an even higher penalty for providing care over state lines. So if anything, that pandemic level, the CARES Act that was passed that allowed that cross state lines convenience of care has gone away significantly. And there are, there are professional punishments if you practice in a state, quote unquote, practice where the patient is where the practice is happening. So if you practice in a state where you don't have a license, you can lose your medical license. And also, most importantly for the hospitals, they don't get to bill you. So that part of care coordination is part of the Cancer Survivorship Act. And I have found that in our patients that live across the Virginia border. So there is not a cardiothoracic surgeon between Winston-Salem and Charlottesville. So we have a lot of patients that live about 2 hours away, just over the North Carolina border in Virginia, who want to come down and get their cardiothoracic, or have to come down and get their cardiothoracic surgery in Winston-Salem. So I think part of being part of that Comprehensive Cancer Survivorship Act is increasing access to telehealth, which is absolutely appropriate for a patient like for a cancer survivor. I shouldn't say a patient like you, but for a cancer survivor, is to be able to access telehealth and to improve access to care for patients. So it sounds, I am more convinced that cancer survivors need to unite their voices in demanding systematic care for cancer survivors. And you've done enough. It's not fair. You are cancer survivors. People, quote unquote, should be advocating for you. But I think there's still this reticence to accept that cancer survivors deserve more than just to be alive. And so I have become, from my view of the challenges of providing survivorship care, I think that a systematic and a whole approach to making survivorship care more accessible to people is where it's got to come from. And unfortunately, in healthcare, that movement is not going to happen without patient pressure and without reimbursement.
If I might ask a question, because actually before I think you came on, we were talking about this, and we use the term survivorship, and you defined it. And I know that the NCCN has the statement that from the moment of diagnosis you're considered a survivor, but there's really a pushback because people are living longer, but they're not, like, they don't consider themselves survivors because they're still fighting, and they're in the trenches fighting tooth and nail with this cancer. on targeted therapies, on immunotherapy, as you mentioned. And, there's a trend where, they say, I don't feel comfortable with that label of survivor. Mm-hmm. I am living with lung cancer. Could you address that, Dr. Wentworth?
Yes, I think so. And this is, I think this is an identity issue, and to me, it's a policy issue. And I think that the identity for patients, I totally get that. And in my experience, I think health systems like to call patients survivorship from diagnosis through survivorship, because in the past, patients were just alive or dead with cancer. It was a binary. And if you were alive, we patted ourselves on the back. This is long before, actually, I was an oncologist, but you patted yourself on the back and said, hey, they're alive, and that's all that matters. Because up really until the 80s and 90s, we weren't curing a lot of cancers. And so that mentality, those oncologists that trained us to think about alive or dead, that sort of binary status. It was only those on the edge of thinking that started to say, and I will say this started with childhood survivors of pediatric cancer who are about 10 to 20 years ahead of us in adult oncology, that started to say, hey, these people have problems related to what you do, and you need to start listening to them. And so I think personal identity is one thing, and there is a lot to be said, and there's a growing amount of literature that how patients want to be identified is very important, and I 100% acknowledge that. And I think that living with cancer is also something that maybe is something that even patients who are quote unquote cured think of too, because it never really goes away. It's still there in the back in that chair over there, even though it's not in front of you. It's still kind of something that can think about and rear its ugly head every once in a while. So I think there's a personal issue, and then there's like a policy issue of how do we get this thing moving? And what I have become more passionate about is how can we organize together to move what our eventual goal is forward on a bigger level. I've been sort of working like Dusty in the trenches on an individual and an institutional level. And what I realize is as I'm in these conversations that we spend 45 minutes figuring out what survivorship care is. And survivorship care to some people is palliative care. And then it's, it's navigation, and it's this and it's that. And then it gets just all of this stuff. And what it really needs to be is support for patients. And so I think it's helpful to identify how patients feel is in line with their experience of cancer, from getting the resources paid for and available, sort of like Fred was talking about. I think that framework is quote unquote after cancer, and it doesn't invalidate the personal experience of cancer, but we I think are going to have to organize together to get this over the finish line.
Follow-up question to what I presented earlier. I'm active with my chart with all my doctors, and I will address kind of a question to Dr. Hales at Hopkins, and probably the reality is his nurse practitioner or RN will intercept my chart, and the nurse practitioner or RN, may actually answer my chart question. They're at a different level than the radiation oncologist. I wonder if that's kind of a communication middle ground that does not put the doctor in a potential liability problem.
Not usually. In my experience, nurses and nurse practitioners are usually better at listening to patients than doctors are. So you're probably getting more listening, and a well-trained nurse. If a doctor is turning over their charting in any way, shape, or form, it's because they have confidence in the staff that they are that they have trained. And I do think that, in my experience, nurses are better at resourcing and connecting patients to resources than physicians are. And trying to change the way that doctors think, I think, is going to wear all of us out. And I have been trying for 5 years as a doctor. But I think that we've got to come at this survivorship from a different aspect. And I think that nurses and nurse practitioners are going to be a huge part of that.
Well, I agree. Maybe I mispresented point I was trying to make. The nurses and nurse practitioners write back to me. And are they getting around the system? That's basically what I'm saying. Or is the doctors not willing to do that because of the rules?
Oh, no, the doctors definitely can, but most of the time, if you think about, like, I probably have 2,000 survivors under my care and active treatment, and there's just not enough time in the day to respond to everything. So most concerns, if there's something out of the ordinary, nurses triage things all the time, or my nurse comes in and asks me, and then they're just the ones that actually like type it and put it in the computer. So usually that we tend to, some doctors manage their inbox. I mean, there's different practices for sure, but most of the time the complaints or the communications are going through the doctor and then being addressed by the appropriate person.
Can I say that with my thoracic oncologist and my primary care, when I send them a message through my chart, I get a fairly quick response. It's almost always either an RN or like you're talking about, Dr. Wentworth. But Fred, I guess I'm lucky because my doctors must kind of keep up with this. At least with me and my cancer, my primary is phenomenal because ultimately within 24 hours, besides the response from the RN, I'm getting a response from the doctor. Mm-hmm. So I don't know if that's something, sometimes to begin with, Fred, I would include a note in my complaint or my discussion saying, please make sure my doctor sees this. So I think that helps. Try doing that at least.
You know, that's not my hang up. It's my doctor who's outstanding. Just says, Fred, it's the rules and I can't write back to you. I can't do telehealth. Come see me in Baltimore. And, you know, I live in.
Oh, right. Yeah.
It's an expense and trouble to get to Baltimore every other week or whatever. Anyway,
of course.
Enough of my frustration.
Well, so have you ever considered moving, starting with someone like in Dr. Wentworth's practice in North Carolina? You have phenomenal doctors there. It'd be a 2.5-hour drive from Wilmington to Raleigh, for instance. It's going to be easier than having to get on a plane.
I was diagnosed in 2020. I'm not going to make a change at this point in time.
Okay.
And the good news, I have a 28-year-old daughter that lives in Baltimore, so I have personal reasons to go there as well.
Well, that helps. And
enough of my story.
For lack of a better word, I could see why it could bother some people, but you know, how many nouns do we have for us? Patients, survivors. So, because I'm thinking nouns, so that's why I said I just go with survivor because I am surviving cancer, so I am a survivor. But I put a little, you know, for now anyway. So I'm wondering if that's why the word bothers people, because we know it's always there, but we are surviving it now. Some of us thriving, some not, but we're all surviving it. So that was just my feelings on it.
Let's just thank Dr. Wentworth again, because we want her patient to get attention as well. So Dr. Wentworth, thank you so much.
And thank you again, Dr. Wentworth. We look forward to seeing you on Saturday. Thank you.
Of course, yeah. And if there is sort of feedback and you guys think that there's something we need to be advocating for, really, I would appreciate that. I think we don't do enough listening to patients and to integrate sort of where we want to go. So I really appreciate everybody being here and thinking about this. So thank you.